And now to our first exciting speaker, Bea Grause. She's president of the Healthcare Association in New York State, otherwise known as HANYS, who will kick off our conference. HANYS represents 500 not-for-profit and public hospitals, nursing homes, and other healthcare organizations. And boy, has that model changed in the last 10 years. We've talked about that in all our sessions. Every model's broken, every model's changing, and unless you adapt and change with it, you're going to lose. So it's great to see that we have somebody of Bea's stature involved with our health care. HANYS members are not only the largest providers of patient care, they're among the largest employers in many communities. She's both a nurse and a lawyer, which is an oxymoron, and a lobbyist, so she's touched all the bases. And prior to joining HANYS, Bea served as president and chief executive officer of the Vermont Association of Hospitals and Health Systems for 14 years. In that position, she successfully led Vermont hospitals through a variety of reform initiatives, including the state's single-payer debate, continuously and intentionally building the hospital's brand as trusted, competent leaders. There's no one better who can explain how what happens in Washington has a great impact on New York. Ladies and gentlemen, it's my pleasure to introduce Bea Grause.
Good morning, everyone. And thank you so much, Bill, for such a great introduction and for your heartfelt remarks. It's a perfect setup, actually. You know, as Bill said, I'm new to New York, but not new to healthcare, and he described a little bit of my background, but I wanted to also add that, I started my career first as an emergency room and an ICU nurse, and then wound up going to law school, and while I was in law school, I couldn't figure out what I wanted to do. I was, tens of thousands of dollars in debt, and wanted to figure out, whether or not a law firm would make sense for me. And I heard Senator Rockefeller speak around a single-payer healthcare system, and I decided then that I was going to move to Washington to try to figure out what healthcare was all about. So I wound up going to Washington, and I wound up working for 2 different members of Congress. And then I wound up becoming a lawyer and a lobbyist, and then wound up going to Vermont. So I've been in healthcare my entire career. And Bill also talked about HANYS. We have an office in Washington, D.C., and in Albany, and we have 3 areas of focus: advocacy, public policy, and education. And public policy, really, I think of as coming up with new solutions for how we address healthcare, and advocacy is obviously fighting and trying to influence solutions both in Albany and Washington. But I'll certainly speak today as the leader of this nonpartisan organization, but I'm also going to talk to you as a consumer, a taxpayer, and most importantly, as a parent and a family decision maker. And I'm assuming, and I think as Bill said, that you're listening with the same array of hats. So there's HANYS. So as you can imagine, I do a lot of explaining in my job, and when I began preparing for these remarks today, I was initially focused on trying to explain all of the things that are wrong with healthcare, and I think certainly many in the audience, there's a lot that's could be better, I think I would say. And as I pored over the many reasons, certainly highlighted here in this word salad, I concluded that our biggest challenge is affordability. Healthcare spending consumes 1 out of every $5 our country spends today, and is among the fastest growing sectors of federal and state budgets. At a macro level, healthcare spending is driving all that partisan bickering that you're hearing in Washington. And at a micro level, healthcare costs are creating headaches around our kitchen tables. And I'll explain why in the slides ahead. And certainly opportunities abound too. Too many to outline today, and I've concluded that there is actually one major opportunity, and that's represented by all of you here today. For the biggest reason is you create jobs. good jobs. And for every job you create another job as part of the economic ripple effect. And jobs are good for many reasons. Obviously, they create private sector and public sector revenue, and that's a good thing. But they're also good because they create hope and purpose for families and communities. And I have long believed jobs are the most effective antidote for depression and despair. Second, the business of healthcare reform is like fixing an airplane while you're flying it. We have to live in the system that we're in while we're trying to innovate and invent something new. This reality begs for disruptive innovation. And all of the ideas and the technology solutions that you're working on today is part of that very necessary process. But to be effective, innovation has to get to the core of what are the challenges around healthcare reform, and that's really in the patient-provider space, how we change behavior. And all the policy gyrations and all of the gadgets in the world are useless unless they move us to healthier behaviors in healthier communities. While it's important to understand the challenges and the opportunities, they're useless without understanding where we actually want to get to. And I'm speaking now explicitly outside of the political realm. I think as many in the audience know, we have long established healthcare goals for decades. They used to be the 3 goals of cost, access, and quality, improving care while reducing health spending, otherwise known as the value proposition. These 3 goals were actually included in the Affordable Care Act in 2010. The goals of reducing per capita spending, which is cost, improving the patient's experience of care, which is quality, and improving population health, or access, are collectively known as the triple aim. And the wording was changed to lend these goals to actual measurement. Some of you have probably never heard of the triple aim. I know many have, but obviously it's not part of the political narrative. The narrative that puts us into an either-or choice of single payer with Bernie on the left and free market solutions with Senator Rand Paul representing the right. The longstanding truth is that the very real and complex underlying reasons for healthcare cost growth are not partisan. They are very complicated and deeply embedded in the existing state and federal infrastructures, and frankly, go well beyond the borders of healthcare and extend into issues of economic growth, poverty, and race. As you continue to be the opportunity makers and take steps to improve and shape the future landscape of New York's healthcare system, recognize that if you accept this either-or narrative, you will become a victim to it. As leaders in healthcare, business, and technology, we cannot allow our political leaders of either party to continue to shape this country's debate on healthcare into an either-or discussion. They are doing us and the nation a great disservice by focusing on ideological solutions that don't help us grapple with the deeper issues. And so what are some of those questions? Is healthcare a right? Can we afford to cover everyone? Does everyone deserve to be covered? Who should pay for people who need a lot of medical care? Should there be a limit on how much care people should get? And there's a spoiler here. That's an easy question to answer unless it's your mother or yourself or another family member. Should we continue to ignore deficits and the $20 trillion federal debt and other national priorities to fund health care? Should everybody have financial skin in the game? How do we turn this healthcare battleship, 20% of our industry, of our economy, so that we are laser focused on prevention rather than churning around money-making interventions? Last, but certainly not least, how do we stay the course, understanding that the solutions to these and other questions will take years and years? Certainly longer than the 2018 midterm elections, and definitely longer than the 2020 presidential election. These are questions that we need to ask together. This is the dialogue that we need to develop to develop viable long-term solutions. This dialogue at the political level simply will not happen unless we demand it. So for my remaining time, I will briefly outline why I have come to these conclusions and why it's important to focus on achieving affordability at all levels, and why you, as business and technology leaders, are at the center of the opportunity to help achieve the triple aim. So let's talk about healthcare costs. As I alluded to before, I could talk for hours about the drivers of healthcare costs, and at HANYS, we're working on all of the items in that yellow box. That's our job. The bigger issues are the societal changes and demands, such as consumerism and chronic disease. These societal realities are longstanding and cut across economic and party lines. We can't solve them so much as manage them. So let's look at the basic equation. And you all know the basic economics is volume times price equals cost, total cost. So let's look at what's driving volume. And the most obvious is demand. Demand with an aging population. We're all getting older, unfortunately. I have faced that reality myself. And the older we are, the more per capita spending we tend to consume. Let's look at the relative health of our population. So this slide shows that in 1993, generally, the obesity rate was largely at or around 15%. As a colleague of mine told me many, many years ago, the way to think about health spending, he said the issue is in the tissue. So the healthier we are, the less spending we have. But unfortunately, this is the picture today. And it generally shows that the obesity rate in this country is at or around 35%. I was in Washington, D.C. a couple of weeks ago and talked with a colleague of mine from Florida, and he told me that the overweight plus the obesity rate in Florida was 65%. And I am sure that that is the case in many of those red states, red and deep orange states as well. Obesity, as you know, leads to other illnesses such as cardiac illness and also diabetes. And this slide just generally shows, too, the rate of diabetes in 1995 and 2010. It has more than doubled, from 4% to 8 to 10%. And I'm sure, since this slide is a little bit old, that that rate is even higher. And again, that increases medical costs. You'll talk about the opioid epidemic today, and I couldn't agree with Bill more about the challenges that we face with this new public health crisis. This slide, you can see the blue becoming red, and the slide represents the red on that slide represents greater than 20 opioid deaths per 100,000 people. 91 people die every day from opioid overdoses. But when you think about this from a demand perspective and why that increases volume, you have to think about what this also represents. And this represents the people who need Medicaid-assisted treatment, the people who are in our hospitals today who are suffering from infections and endocarditis related to IV drug abuse. It is driving up medical spending in every part of our healthcare system. And it raises questions of how do we parse our precious resources between treatment and prevention. So that's the demand side. So let's look at the price side very quickly. Prices are obviously a major driver of health spending. It's a complicated topic, but in general, in the United States, we pay higher prices for everything. Higher prices for lawyers, for accountants, for construction workers, and we have for decades. That is just a part of a reality of our economy. In healthcare, we're a local service governed by state and federal law, but largely the care is personal, provided by highly skilled, well-paid professionals who need constant training and support. Hospitals also pay to recruit and retain physicians to their communities, and for the most part are responsible, of course, for the training of and recruiting of all types of highly skilled health professionals. Hospital budgets are 2/3 related to payroll. And in other sectors, such as skilled nursing facilities, it's closer to 80%. These professionals use very expensive tools, as you know, particularly at the hospital level. The constant evolving array of diagnostic and surgical devices contributes to rising prices. And in hospitals, it's our mission to keep our doors open 24/7 to all who need care. And again, this is the most expensive sector in the whole industry. And federal law, and I would argue our longstanding values, require that we treat every patient the same. There's no economy model. There's no economy model for cardiac care, for example, regardless of our ability to pay. So this is our safety net, but it is, again, it is one that is very costly that we pay for in that infrastructure. And contributing to all of this, both to higher prices, is how we're paid. And again, this is a lot of the work that we do at HANYS, is working on payment reform. But largely today, we are still churning around a system that is built around transactions. And this drives volume without necessarily focusing on the value. So who pays for all of this? I love this slide. I use this slide a lot. It talks about access to coverage, but it also shows who pays. And the slide, if you look at the red box in the slide, that is employer-based coverage. And the blue slide is Medicaid, green is Medicare. The yellow box are the 29 million who are still uninsured. The blue circled box, again, when we talk about the narrative that we're in and the rhetoric that Bill alluded to earlier, the blue box is Obamacare. Those are the people who receive coverage through Medicaid expansion and who are receiving care on the exchange. And the little sliver is the Children's Health Insurance Program. But we are paying for all of this. You are paying for all of this. You are both ratepayers. You either are business leaders and you pay for employer-based coverage, commercial coverage, or you certainly are taxpayers. So this is how everyone in the country is getting access to coverage, and we are paying for all of it. Also, I will note too, even in employer-based coverage, the government is funding all of this. You are getting tax subsidies on the employer-based coverage, and the government is funding, and the public sector funding at the state and the federal levels are funding the half of that box in Medicare and Medicaid. But again, we're paying for all of that. It's just which pocket do you want it to come out of? So how this all rolls up to politics eventually is just, again, the pressure of health spending, and health spending, as you know, for decades has been growing at faster than our ability to produce revenue to cover it. And you'll see here in 2016 that Medicare and Medicaid, the maroon and the red, are a little less than a third of health spending, which is a little bit deceptive because health spending is embedded in both defense and discretionary spending as well. And when you think about the aging population and look at Social Security spending, you can see that about half the federal spending today is spent to care for people. I will add, as just a little fun fact on Social Security, when we think about related issues like housing, affordable housing, and cash benefits, 1/3 of senior citizens today depend on Social Security for 90% of their income. So it is a critical factor when we think about how are we going to care for people who live in our cities, live in our communities, who have very little and depend on Medicare and Medicaid and Social Security to survive. Again, as I said before, this is not a problem to solve so much as a problem that we together have to manage. This is a slide looking ahead 10 years to look at the growth. And again, in a nonpartisan way, healthcare growth is the pressure on the federal budget. And again, if you looked at state budgets, it would be the same picture, is intense around Social Security and healthcare, and then look at the interest on the federal debt. And you can then, I think, understand a little bit around the divide that's occurring in Washington today. But we don't see that. Most of us don't see that, you know, in terms of healthcare, the whole picture. And so most consumers are really just focused on what's above the surface, not really understanding the driving healthcare costs that are happening every single day that we're paying out of primarily our tax, you know, the pocket that's paying for taxes is paying for the drug-addicted babies and the brain-injured teens who are living in a nursing home. They don't think they're paying for it, but they are. And the debate is mostly around what's on top of the surface, because again, particularly with the ACA repeal debate that we've been living through, has really been around premiums, but premiums are really just part of that picture. Certainly we have premium growth. It's actually slower today than it has been in recent years, but it is the political driver, because with the angst around high commercial premiums, that puts pressure on politicians to address that, which they do by reducing public sector spending growth, largely by reducing payments to providers. And we have a couple hospital CEOs in the audience today, and they know when the government reduces their payments, they have nowhere to go if they're going to keep their doors open and maintain a margin. They have to increase their overall prices, and that in turn puts pressure back on those commercial premiums, and so the cycle continues. So if you're not thoroughly depressed, I'll move on to opportunities. So, and certainly none of these are easy to solve, but it doesn't mean we haven't been working on them. And there are lots, I think my main point around the opportunities is that just like, you know, it's more of a journey. There are no magic solutions, there are no quick fixes around opportunities, but we have been working on many, many opportunities that are really trying to get at the core of the problem, which is reducing demand and reducing price to try to reduce health spending growth over time. And they're in basically 4 categories: payment innovation, system redesign, technology, and public health initiatives. One of the things that people don't talk about with Obamacare or the Affordable Care Act when it passed in 2010 is it really put gas on the fire for starting innovation around payment reform. And we, in the healthcare community, both in New York State and across the country, are working on a lot of these initiatives. I'm not going to explain the language salad here around accountable care organizations and bundled payments, but it really is around improving that value proposition in a way to hold providers more accountable for the care that they're delivering and make sure that as consumers we are getting more value for the dollars that we are spending. And these initiatives are ongoing. There are many initiatives at the state level, and I've been proud to work with the state of New York. They are very active on healthcare reform. It's one of the reasons why I was interested in coming here, in that New York really does do quite a bit on both working with the Medicaid program through the Delivery System Reform Incentive Payment, otherwise known as DSRIP, but also working across payers to help primary care physicians transform how they do their work in order to improve that value proposition, as well as dealing with and working with people with chronic illness and what's known as the dually eligible, who are low-income seniors who are eligible for both Medicare and Medicaid. This is just a slide to say, again, this is these projects are happening, they're ongoing, they're part of that journey. They are happening in both rural areas and, of course, in urban areas. And there have been results. And again, when you think about the triple aim and thinking about lowering per capita spending, the state of New York has been able to lower per capita spending. I think in terms of total spending for Medicaid in New York, spending growth has continued to rise because through the Affordable Care Act, more than 2 million New Yorkers were able to gain coverage through the Affordable Care Act. But again, it's a good news story. In the private sector, there have been and continue to be a journey toward changing that provider-payer relationship. I think much as many of that you are doing as employers, where you are working with the population you have in order to, and providers and payers together are looking to figure out how do they change payment, how do they redesign care, how do they work better together in order to improve health and lower spending at the same time. And these are all, again, these are all good news stories. The question really is are they scalable? Are they spreadable? Can that be adopted across, in both state policy and federal policy? And then in private sector redesign, a lot of this is happening as part of just market dynamics. And this is, I think, a good news, bad news situation in a way. It's good for consumers, I think, for the most part. We have had a very, what I call an enterprise-centric system, big hospitals where people have to go to the hospital or go to the doctor's office to get their care. That is really starting to change, I think, as you well know. And, and I think, so for consumers, that's good. For providers, I think it's a challenge, again, because where patients go, there goes the revenue. And since we are still largely in a transaction-based system and are a fee-for-service system, hospitals depend on that volume in order to make a margin. And so it has certainly created challenges in the hospital sector. But again, I think we're continuing with that, and it's a good thing. Obviously, technology, I think, what I've been focused on most recently is telemedicine on the regulatory side, and I can tell you the state of New York is very actively working on updating their regulatory infrastructure to support the advancement of telemedicine. And again, telemedicine, medical devices, all I think are moving us to a patient-centered system where it's either going to be our computer screen or frankly our cell phones that will be the center of how we are making most of our decisions. And we are just beginning on that journey. Again, it's these disruptive innovations that will really, I think, again, cause some pain for some in the industry, but I think overall, I think it's a good thing. It's a question, though, however, of how do we manage the haves versus the have-nots, where we have, again, as I was alluding to before, where we have 1 out of 3 New Yorkers, for example, are on Medicaid. So where are they going to wind up getting their care? And so we can't really race to try to provide solutions only for people who can pay for them. We have to understand that because we're paying for the whole system, we have to manage how these innovations are going to impact the entire healthcare system. Otherwise, we're kind of shooting ourselves in the foot. And again, as I said, we're just barely on this journey, and we have to understand, and you all know this as well, that the next generation has high expectations of us. We will, I was giving an interview a couple of weeks ago, and they asked me after an hour, they said, well, do you have any questions for us? And I said, sure. What do you find most frustrating about the healthcare system? And they, without blinking, they said that you haven't fixed it already. So again, we're going to continue to meet those demands. And I think a question around technology certainly is what's the return on the investment? From a public policy perspective, is all this investment in technology, is it reducing health spending? Is it reducing per capita spending? Is it improving that value proposition? In some areas, there's pretty clear evidence, but I think the jury is still out. And again, who pays for all of that? Lastly, public health initiatives. In New York, I think New York is certainly a leader on public health initiatives, but as a country, for decades, we have underinvested in public health, and the slides I showed you earlier allude to that. How we incentivize people to change behavior and improve their health, that is the $3 trillion question. And, and again, I think we can get answers from you as business leaders in your efforts to improve the health of your employees. And so this leads me to politics and my conclusion. So for someone like me, the repeated efforts to repeal the Affordable Care Act have been a high wire act, one or two votes 3 times. And while it's over for now, you can expect the debate is going to continue for tax reform, mostly because the Medicaid cuts, the $940 billion in Medicaid cuts that they were looking to obtain through repealing the Affordable Care Act are needed for tax reform, and I would argue that it's more tax relief than tax reform. So we do expect that threats to the Medicaid program will continue. And the challenge is that those cuts without policy changes, as I said before, to improve the value proposition, threaten to take us backward from the triple aim, because you leave people without coverage, then they wind up, they have less access, and then they wind up in the emergency room, which is, again, is where we don't want people to be. You're hearing a little bit now about a bipartisan effort to stabilize markets, and I think that will happen. Again, I see it more as a Band-Aid for what really needs to wind up happening. And so what's your role in changing this narrative? So the current political divide, as Bill alluded to before, goes something like this. The political left doesn't want to talk about the cost of entitlement growth, and the right doesn't want to talk about need, the 1 in 3 New Yorkers on Medicaid, for example, and how we are very ineffectively and wastefully meeting that need. And as I have said many times already this year, the GOP is not wrong to be worried about the $20 trillion debt and the $1 trillion a year federal deficits. Hurricanes aside, we have to look hard at all areas of federal spending to lower interest payments on the federal debt and begin producing balanced budgets again. But even without tax cuts, it will take perseverance and green dollars to support the innovations and opportunities that have been ongoing, that are just getting started, but not yet hardwired into a new way of delivering cost-effective care to those who need it, and rethinking how we can take full advantage of the innovative forces of the market and business leaders like yourselves to help us figure out how to fix the entire delivery system, not just for zip codes that have a predominance of paying customers. So there are no magic solutions, no easy fixes, but together we can focus on the real facts and the real problems. And if we focus on it, politicians will too. You aren't going to walk out of here an expert, but like everything you do, you can get there. And as the saying goes, attention is the currency of leadership. So take the time to read a little bit every day, and I highly recommend Atul Gawande's article, and this is from his most recent one. He wrote an excellent piece about exploring what Americans think of healthcare as a right, and it's very worth your time. The bottom line is, if you aren't going to grapple with these issues, who will? As someone who's been a caregiver and who represents providers of care, we want and need you at the table. We can no longer afford to have a debate defined by solutions without first understanding the issues, and of course, the right questions to ask. Thank you. I'm happy to take any questions if you're not thoroughly depressed. Anybody want to know what the president's going to do next? I don't know. I will say, you know, I do think that oh, good. There's one question here.
Keith Safian. One question for the business people and the community. What steps can they take now to help guide the next phase of the process?
The phase of the process in Washington, do you mean? Yes. So I think I would, I know Kevin Dahill is in the audience here too. I think you do what I suggested you do, is that you start asking them questions around how we are going to manage the problems, manage the realities that we face as a society in healthcare. What are we going to do around addressing the need at the same time we are trying to balance the budget, and how do we adjust those priorities, and start to ask them to really start to grapple with those issues rather than coming forward with whether they support a single payer or a Medicare for all solution, or whether or not they think the answer is free market solutions. Because that really, what's happening is they're speaking past one another and asking them to come together to really start to address and talk through some of the questions that I outlined, because I think if they have to talk to each other about, for example, how do we handle people who have high medical needs? What are the policy solutions on the table? That's a very different dialogue than talking past each other to say, I think they ought to enroll in Medicaid, or I think we ought to require the states to do that. Let's put all the ideas on the table and talk and look at data and try to understand what makes sense for us as a society. I think that's how we start. All right, thank you.